this patient was referred to us for endodontic treatment of tooth number 15. Patient stated that he had a filling in the tooth. Filling had come out, and when I saw his dentist told him he needed the root canal. His dentist put a temporary filling in his tooth and referred him to us. So the dentist didn't drill on the tooth or anything, just there was a hole in his tooth, he said, and the dentist filled it with this temporary filling and referred him to us. So as you can see, that's the temporary filling the dentist put in, decay right here into the pulp. All right, and irreversible pulpitis with acute apical periodontitis. You can see this lucency right there. Okay, I can tell you with certainty that this is not a periapical lucency. This is because when there is severe irreversible pulpitis, you could get something like this that resembles a periapical lucency that's usually associated with a necrotic tooth. You can get that on a tooth with irreversible pulpitis. You can get this. So this is not always a sign of pulpal necrosis and infection, because in this case, the pulp was definitely a vital pulp when I did the root canal. So this is a periapical lucency, but it's not a periapical lucency because of infection, pulpal necrosis and infection. All right, that's what I'm trying to get at. Anyways, so that was 9/24/2024 when I saw him. So a couple of weeks ago when I saw him for the consult. So we scheduled, and he wanted to come in today. When he came in today, we had this. So as you can see, he had lost the temporary, and I asked him, how did you lose this temporary? And he said he was eating gummy bears. Gummy bears are a no-no when you have a temporary filling in your tooth. So he said he was eating gummy bears, and it just pulled the whole temporary right out of the tooth. All right. Anyway, so but he was here today for the root canal, so it made no difference to us. But don't eat gummy bears if you have a temporary filling in your tooth. So what did we do today? Of course, local anesthetic, and this patient was very anxious, by the way. Tooth number 15. Local anesthetic. I placed the rubber dam, and immediately he says he can't breathe, and he's starting to panic. So I calmed him down, and I asked him if he wanted me to remove the rubber dam, and he said, no, it's fine. I just can't breathe. I feel like I can't breathe. So I cut a little slit in the rubber dam so he can breathe. All right. Also, he had a hard time. I think he had a post-nasal drip. So I sat him up a little bit more. So because I use a microscope, I like the patient to be flat. But in his case, I brought the back of the chair up so he could breathe and he was more comfortable. So these are the little things that we can do. Then he started complaining about his neck hurting. And again, we address it. We don't just say, oh, tough it up, you know. One of my assistants went and got him a pillow for his neck. All right, so those are the things that we can do to accommodate the patients and care. You know, you have to care. You have to care. You have to be compassionate. You have to have passion for what you do. Now, I put a bite block in, and he said he couldn't handle the bite block, so I had to remove the bite block. So I got in, was able to finally get started. Of course, rubber dam. No rubber dam, no root canal. All right. So I told you about what happened with the rubber dam. He couldn't breathe, had to cut a little slit in it so he could breathe and all that stuff. Anyways, cleaned out the decay, rebuilt the missing walls, and then and only then made my endo access. And when I made my endo access, when I cleaned out all the decay, there was very close to pulp exposure, very close to pulp exposure. I could see, you know, a little bit of blood there. Again, some people will ask me if why didn't I do vital pulp therapy and all that stuff, and watch my video on vital pulp therapy. Okay, so I made my endo access, and there was definitely the pulp was in the state of irreversible pulpitis, just bleeding profusely as soon as I made my endo access. You can see a pulp stone there. Remove the pulp stone. These were 27 millimeter long roots, MB1, MB2, distal buccal. Palatal was 29 millimeters long. So 27, 27, 29. So I had to use 31 millimeter files on this patient who was complaining all the time. He just had a hard time. And couldn't keep his mouth open. As I said, I tried the bite block, but he just couldn't tolerate it. And take a look. We're able to do this root canal for him properly. We took our time and did the root canal for him properly. And here's the post-op. Look at the curvature of the distal buccal canal. So 27 millimeters, 27 millimeters, 29 millimeters right there. As you can see, everything went beautifully. We went ahead and temporized the tooth and referred the patient back to his dentist for the permanent restoration. That's another angulation. That's another angulation. This is not a broken file. Don't be telling me that now. That's gutta percha. All right. So everything went great, as you can see. We went ahead and temporized the tooth and referred the patient back to his dentist for the permanent restoration. And of course, I documented number 14. Decay there, as you can see, recurrent decay. And the patient's report to his dentist. But our job here was done. And as I said, refer the patient back to his dentist for the permanent restoration.